surgery. And it's very appropriate that we make a distinction between gastrointestinal and non-gastrointestinal surgeries, because the nutrition or nutritional needs in a patient who has contraindication to enteral feeds is very different compared to other patients who can be given enteral and even oral feeds. So what I would try to cover is the role of enteral or intestinal nutrition, parenteral nutrition, and specifically talk about some things relating the perioperative nutrition in a conventional and ERAS protocols. And these are, I'm sure, the surgical residents, if there are any in the audience, would know that ERAS, enhanced recovery after surgery protocols, are the most interesting and most promising ways to improve and enhance or fasten the recovery process following surgery. And there are certain other nutritional issues such as micronutrients and immunonutrients, which we'll cover in very short. So in a patient who's undergoing surgery, or the surgical patient as such, before, during, and after surgery, what are our goals of nutritional support? These are to prevent or to reverse any catabolic effects of the disease process itself, meet the requirements or the energy requirements of the metabolic process, which includes the needs that emanate out of the hypermetabolic state of the disease and the surgical process and the healing. Another goal is maintenance of normal body temperature, and then finally also to provide substrates for tissue repair and healing, because these are processes which require quite a bit of nutritional support. So one important thing before we go ahead, we need to understand very clearly how do we estimate the energy requirement. And in context of the in a perioperative patient, this assessment or estimation of energy requirement should be done preoperatively based on the history, physical examination, the body weight and the BMI of the patient, and with biochemical assessment, including assessment of albumin and blood counts, creatinine excretion, and serum transferrin. And this formula for calculating the resting energy expenditure, which is the Harris-Benedict equation, can be found anywhere. I'm sure you would have any number of resources where you can find it. But it is important that we calculate the calorie requirement by calculating the BEE, which is then multiplied by the activity factor and the stress factor. So there's another way of doing it, and that is by indirect calorimetry. And again, resting energy expenditure in kilocalories per day can be estimated using a standard formula. Yet another way of doing is by dual energy absorptiometry, where we measure the lean body mass, the fat mass, and the bone density. We also have to be very well versed with the daily electrolyte requirements, and the most crucial of them are the sodium, which is required in about 100 to 120 milliequivalents per day, potassium 80 to 120 milliequivalents per day, magnesium 12 to 15 millimoles per day, calcium, which is required around 5 milligram per day, and phosphorus 14 to 16 millimole per day. There is a whole host of micronutrients, and these include various ions, iron, zinc, copper, chromium, selenium, manganese, various vitamins, vitamin E, A, C, D, K, and then various amino acids and various other micronutrients. And then there are standard daily requirements. Once again, you can find these in any resource, but these are things that we need to be well versed with. So, in a patient who's about to undergo surgery or who has undergone surgery, what are the guiding principles for ensuring appropriate or adequate post-op nutrition? One should use the oral route if the GI tract is functional and there are no contraindications to oral feeding as much as possible. We should try and initiate the enteral nutrition if the patient is not expected to be on full oral diet within 7 days post-operatively and has no contraindications to or GI contraindications. If the enteral route is contraindicated or is not tolerated by the patient, for example, a patient with intractable vomiting or paralytic ileus, then the use of parenteral route within 24 to 48 hours following surgery is advisable in a patient who is not expected to be able to tolerate full enteral nutrition within 7 days. Another guiding principle is that we try and administer at least 20% of the calorific and protein requirements enterally while reaching the required goal with additional parenteral nutrition. Maintain parenteral nutrition until the patient is able to tolerate at least 75% of calories through the enteral route, and enteral nutrition until the patient is able to tolerate 75% of calories via the oral route. So, in a way, in a patient who's on parenteral nutrition, the first step down is enteral nutrition, such as through anasogastric or jejunostomy or other routes. And then the next step down is to oral route whenever the patient is able to tolerate at least 75% of calorie requirements through these routes. There are numerous possible contraindications to enteral nutrition, and these include intractable vomiting and diarrhea, which are refractory to medical treatment, paralytic ileus, distal high output intestinal fistula, which are too distal to bypass using various feeding tubes, intestinal obstruction, intestinal ischemia or peritonitis, severe shock or hemodynamically unstable patient, severe GI hemorrhage, severe short bowel syndrome, less than 100 centimeter of small bowel being remaining for use, severe GI malabsorption, for example, enteral nutrition has failed, as evidenced by progressive deterioration in the nutritional status, and this would result in inability to gain access to, or in patients where one is unable to gain access to the GI tract, and if the need is expected for less than 7 days. Once again, enteral nutrition is contraindicated. So one can have an algorithmic approach to the nutritional assessment of the patient to identify what are the needs of the individual candidate for nutritional support. If there are contraindications to enteral nutrition, then parenteral nutrition has to be considered. Short, if this is required for short term, one can do away with the central axis, and a peripheral parenteral nutrition can be used. If, however, there's an anticipated long-term need for parenteral nutrition, then a central parenteral line should be instituted. And then once the GI function returns, one can reverse to oral intake, or one can switch down to oral intake as indicated. If, however, there are contraindications to enteral nutrition, if there are no contraindications to enteral nutrition, it is better that we institute enteral nutrition, either using gastrostomy or jejunostomy tube when one anticipates long-term requirement, or using nasogastric or nasoduodenal or nasojejunal tube when short-term requirement is required. This is anticipated. And then after return of GI function, and depending on the tolerance, one can switch down to oral nutrition. So enteral nutrition is always preferred over parenteral as and when possible. And there are various routes of administration we can use: nasogastric, nasoduodenal, nasojejunal, gastrostomy, which can be either percutaneous or endoscopic, or under intervention by interventional radiological intervention, or jejunostomy, once again, that to be can either be percutaneous or endoscopic, or by interventional radiology. The advantages of enteral nutrition are many. It provides the advantage of trophic feeding and results in maintenance of structural and functional support of the intestinal mucosa by providing glutamine and by preserving blood supply and promoting peristalsis. Enteral nutrition also results in maintenance of integrity of the intestinal mucosa and thus prevents bacterial translocation and sepsis. And it is also relatively inexpensive and easy to administer and safe. So total parenteral nutrition, as and when required or essential, is used in way of intravenous infusion of nutrients in elemental forms. It is associated with a higher cost, possible complications, which limit its use, but uh, it is essential in patients who have contraindications to enteral feeding, as we have discussed earlier. It must be patient must be hemodynamically stable for the total parenteral nutrition to be used. However, there are numerous exceptions. There are patients who may not be hemodynamically stable, but yet we use parenteral nutrition. Of course, in a patient who has undergone gastrointestinal surgery, total parenteral nutrition is more often required, and this would be covered in another talk during the course of this 01 course. There are certain conditions which require careful use of total parenteral nutrition. In a patient who has hyperglycemia, azotemia, hyperosmolality, hypernatremia, hypokalemia, hypochloremic metabolic acidosis, hypophosphatemia, and hypochloremic metabolic alkalosis. All these are conditions where TPN must be used with due caution and care. Coming on to immunonutrition, that's a whole new concept of, or a different concept of nutrients which affect the immune system. There are numerous recognized micronutrients. These include the arginine, glutamine, omega-3 fatty acids, nucleotides. Uh, राजू इसको फोन पूछ लो, बता दो मैं एक लेक्चर में हूँ. Potential other potential micronutrients which can have immunomodulatory effect are vitamin C and E, selenium, copper, zinc, taurine, branched chain amino acids, N-acetylcysteine, etc. Uh, going, I would not like to go into great details of each of these, but for example, arginine is an essential amino acid and has been shown to have a good role in immunomodulation. Similarly, glutamine, another semi-essential amino acid, omega-3 fatty acids similarly have been shown to have anti-inflammatory effects. And then nucleotides, which are essential for DNA and RNA synthesis, are again known to be having a role in immunomodulation. In patients with there are more and more, we are now using the enhanced recovery after surgery protocols, and these patients, the ERAS protocols, have certain specific different nutritional considerations. What is ERAS, enhanced recovery after surgery? As I said, it involves a whole clinical pathway to accelerate recovery. It was initiated in 1990s by Professor Kehlet, initially with elective colon surgery in patients who were in the usual age groups, where there's a multimodal and multidisciplinary intervention or set of interventions which can bring around earlier or faster recovery after surgery. And the principles that are used here are to avoid any stress and starvation, and to optimize the pain relief, the GI function, and mobilization immediately or soon after surgery. Uh, there is a pre-operative evaluation done over previous 10 days. Uh, then, 1 day prior to surgery, there are certain interventions instituted. So are certain interventions on the day of surgery, and then, as early as possible, the patient is discharged from the hospital. One important principle that comes in handy for ERAS, or enhanced recovery after surgery, is to reduce insulin resistance and promote anabolism. Hyperglycemia, we know, causes inflammation and insulin resistance and can lead to numerous complications. Uh, if there is a 50% insulin resistance, there's a five-fold increase in complications and tenfold increase in infections. So if we can prevent insulin resistance, prevent inflammation, prevent hyperglycemia, we can prevent number of complications and sepsis. Pre-operative nutrition is an important component of ERAS. One must avoid preoperative fasting because that will lead to rebound. The hypoglycemia would lead to rebound hyperglycemia and then insulin resistance and the whole cascade. One must also avoid full bowel preparation unless it's absolutely essential, and provide perioperative nutrition. The perioperative ERAS protocol involves counseling of the patient, not using full bowel preparation, avoiding and then doing fluid and carbohydrate loading before surgery, and not asking the patient to fast for long. Do not use any nasogastric tubes. Use epidural pain control, short acting pain medications, and DVT prophylaxis. Ensuring adequate perioperative nutrition, use of non-opioid analgesia as much as possible, avoiding sodium overload, maintaining normothermia, early patient mobilization, prevention of nausea and vomiting, stimulation of the gut as early as possible, again by institution of early oral feeds, early removal of whatever tubes may have to be used, and perioperative antibiotics. The preoperative nutrition, as I said in the earlier slide, there is no evidence which supports fasting after midnight to avoid aspiration, which used to be the main concern until recently. And so the patient can be allowed clear fluids up to 2 hours prior to surgery and solid food to 6 hours prior to surgery. uh, Provision of clear carbohydrate rich beverage, which is 12.5% of the calorie requirement of the daily calorie requirement. It can be given in about 900 cc at midnight and 400 cc 2 hours prior to surgery, and this will provide almost 600 kilocalorie to the patient, and this will reduce perioperative thirst, hunger, anxiety, and insulin resistance, and so it has potential to reduce perioperative complications and sepsis. The impact of preoperative nutrition on the ERAS protocol has been well studied. A Cochrane review of 22 randomized controlled trials has shown that it does not result in any increase in complications, and it provides similar gastric emptying in patients who are obese or morbidly obese and who have uncomplicated type 2 diabetes, as well as those in lean patients. In post-operative phase, in the ERAS protocols, one institutes early oral nutrition as early as 4 hours post-operative, and one can institute 400 to 600 milliliters per day energy-dense fluids. One can continue oral supplementation for 3 weeks post-operatively, and one must ensure that nitrogen equilibrium is maintained, which results in less hyperglycemia and thus other complications. The perioperative nutrition therapy as has been advocated by the North American Surgical Nutrition Summit. It says that there is it suggests that there is a paradigm shift to concept of prehabilitation. The approach has to be multidisciplinary, where appropriate diet is prescribed, mobility is ensured as early as possible, the volume, temperature, etc. of the feeds or the fluids are controlled, and pre through post operative approaches to be used. Pre-operative nutrition assessment must be ensured in these patients, and then pre-operative nutrition, including immunonutrition, 5+ day pre-operative enteral nutrition, preferred over parenteral nutrition. Parenteral nutrition only if enteral is not possible, and whole soy-based lipids. Post-operative nutrition is to be instituted within 24 hours. Resuscitation improves post-op feeding, and barriers to feeds are the problems that we need to document. In summary, the perioperative nutrition issues that I have discussed. Preoperative nutrition is an important determinant of outcomes in surgical patients because these patients have increased metabolic demands. One must have appropriate assessment of the nutritional needs of these patients and provide for all the components of nutrition which are essential for good recovery following surgery. Understanding of the body's energy, fluid, electrolytes, and micronutrient demands in the perioperative phase are essential. One must use enteral route whenever the gut is available for usage, and parenteral nutrition should be reserved for patients who have a contraindication to enteral nutrition. Preoperative nutritional assessment and addressing or correcting any nutritional deficiencies can reduce perioperative morbidities and mortalities. The calorie, protein, essential fatty acids, and micronutrients, these are all components which need to be provided for adequately in the preoperative period. Immunonutrients is another set of compounds which need to be addressed, and these are components of unclear clinical utility at present, but possibly potential agents which may improve perioperative outcomes. Preoperative carbohydrate loading, minimal period of fasting, early resumption of oral nutrition. These are the current thinking which are leading to better perioperative outcomes. And so that is what all I wanted to discuss. And if there are any questions from anyone, I'll be happy to address those.
Any questions, students? Well, if none, are there any questions?
Well, I was saying that it's a long day for everyone. Perhaps at this late hour of the day, there may not be any questions.
Yeah. So, but so it was a wonderful lecture, very comprehensive, very informative, and that's the reason I really wanted you to take this up, because last year also people really enjoyed and they wanted to have your lecture. So there were demands for the PPTs of yours. So I said they'll be available on the website. So, and thank you, sir, for sparing your time. And it's really late for you as well. And so I'll sign off now, and I'll see the study group tomorrow at 3 o'clock. For tomorrow's lectures are on gastroenterology and gastrosurgery. So please connect at 3 o'clock. Thank you so much. Thank you, sir.
Thank you. Goodbye.